Our case today is discussing a critical issue for interpretation, the Oncotype DX score for young patient with unusual scenario. Mrs. Mona is a 39 years old lady with negative family history, presented with a left breast cancer diagnosis, for which she underwent upfront breast conservative surgery with axillary lymph node dissection. The pathology showed that the patient has invasive duct carcinoma with a grade 2, pathologically T2, as the mass was 2.5 centimeter, with lymph node metastasis, micrometastasis in only one lymph node out of the three. And the patient has a luminal B type 1, type 1. As the Ki-67 was 28%. At this time, we asked for her recurrence of the score, recurrence of risk. According to the data for the recurrence regarding the distant recurrence disease for the T and N stage combined, the patient has a risk of recurrence about from 28 to 37% between that. According to her age, is we consider her age as a risk factor as she is young and premenopausal patient. The data that's published in 2012 showed that the relapse-free survival was less for the patient with age less than or equal 40 years old. And the data was significant. According to the BAM50 analysis and the biological subtype for this patient, we can see that the luminal B in yellow has a long-term survival that is more or less like the HER2 enriched at 10 years. The two curves are above each other, intersect. And for these patients, the options for the Oncotype DX has a crucial prognostic value to identify what is the patient recurrence score. Dr. Luay, do you want to add any information to this slide?
This is about the composition of the Oncotype DX recurrence score. It's simply one good modification of the immunohistochemistry, the one that we are using in Egypt very widely with the estrogen receptor and progesterone receptors. Here we measure the gene expression of the estrogen receptor and the progesterone receptor, and in addition to estrogen-related genes, these are the BCL2 and the SCOP2. In addition to the HER2, but more than the HER2 expression gene, we also have the GRB7, which is an HER2-dependent signaling gene. While we measure the Ki-67 as a measurement for proliferation in patients by immunohistochemistry, yet the Oncotype DX adds four more proliferation genes: the STK15, the cervivin, the cyclin B1, and the MYBL2, in addition to two genes related to invasion. So the group that's in the boxes, those are more or less related to the immunohistochemical basics, the ER, PR, HER2, and the proliferation. And in addition, three more genes that have been proven to be prognostic. So out of that, a big equation that results in the recurrence score And that's, again, one more step in the prognostication for the patient. So all that gene score was developed to add more prognostic value than the typical clinical factors like the immunohistochemistry and the age, of course.
As you advised me days ago to search in the literature for the discordance between the data of the immunohistochemistry and the results in the Oncotype DX regarding the hormonal receptor status. I have searched for it, and I found that the two methods are using a different methods. As you know, that the Oncotype DX look for the receptors by the RNA, and we look for the immunohistochemistry through the proteins. What do you think about that? As the literature or the data that I found that there is يعني a few discordance between the results, but cannot be established enough to be
Yes,
evident.
they are concordant, of course. So patients who are having estrogen receptor positive, they should have a high estrogen receptor signaling in those genes, and those who have HER2 negative, they usually should have a low score, and those who have low Ki-67, typically they have low recurrence score. But this is not 100% discordance. So sometimes we see patients with very low Ki-67 and with immunohistochemical markers that look like pure luminal A, yet we do the recurrence score and we find it high recurrence score, high risk of recurrence. So that's that we have some discordance, but again, relatively low compared to. We have even some discordance between different gene expression profiling. If you compare that to the ROR, the risk of recurrence that's provided by the PAM50 or the Prosigna, you could find some patients who were defined as a low risk with the oncotype, but high risk with the PAM50, for example. So there is some discordance, but let's see what happens with this case, because this is a little bit one more.
Okay, and this patient has a different scenario because at this point we will delay the discussing that issue a little bit. But the question here, do we consider the micro lymph node metastasis as N0 or N1 according to the TAILORx or the RxPONDER? As you know, that one included patient with a negative lymph node, and the others has included the patient with one or up to three lymph nodes positive.
I would love actually to hear the opinions of the audience here. As you look into the RxPONDER study results, it looked like the patients with very young age, they do not, even in the N1, they looks like they gain some benefit of chemo. So that's why many of the guidelines does not support to request the Oncotype DX for patients with N1 disease. So those patients who are typically fit for the RxPONDER study, and they limit the request of the Oncotype DX to the patients who are N0. This means the TAILORx. But let's just here we have an intermediate situation. The patient has N1 MYC, so only one lymph node with less than 2 millimeters deposit in one of the lymph nodes. Of course, that was sentinel lymph node. But what do you think we should follow? So do we consider her as N0 or we consider as N1? You can just type in the chat box if you wish.
I can have my personal bias is this would be an N positive N1 MI, and it does fit into the RxPONDER population. Responder did have, I think, about 10% patient who were N1 micro, and there was a sub-analysis that Helensky presented for the N1 MI specifically, which was not actually, interestingly, statistically significant. There was a trend towards benefit, but then again, you can't really make a statistical generalization because it was not powered for this particular population, so it was mostly like a subset analysis. But there was N1 MI And I mean, by staging, by AGCC, this is a G2N1, still N1MI. So that's my 2 cents. The other question that you mentioned about the suitability of Oncotype in these patients is obviously the million-dollar question. I mean, it's really it's a huge conversation, and I have some biases in that, but I wanted to kind of see how the conversation is going.
Yeah, I think just like to capitalize on what you said, the confidence interval was wide for the patients with the micro because there hasn't been enough patients, and I don't know where the conversation is heading, but we can go back and ask that million-dollar question about the RxPONDER results and whether these patients that have been recruited in that trial 10 years ago had optimal ovarian suppression, because we don't know if chemotherapy works for these patients because of the chemo benefit or because of the ovarian suppression benefit, because we know that in RxPONDER trial, about 16 to 20% of the patients got maximal ovarian suppression. So they were still premenopausal when they benefited from chemotherapy.
So thank you for your input. Yes, those patients, some of those patients went into the RxPONDER, while very few went into the TAILORx, and again the Oncotype DX, the interpretation. Well, they're not sure of it. They're not sure which data to apply on those patients. Well, I've had a meeting with them for that lady, and they tend to consider the chemo benefit within the TAILORx numbers. Of course, the younger patients, they had also some sort of chemo benefit. Again, as you mentioned, not necessarily from the chemo, but maybe from the ovarian function suppression. But even in the TAILORx study, there was some benefit in those young patients. But that's just to clarify that we're not yet sure about how much benefit are there of chemo. But let's see, Nuran, what do we see in that lady?
Okay, I'll skip that. Dr. Luaid, do you want to discuss the TAILORx study designs, or jump to the patient's story?
So both of the studies had similar designs where
Yes.
Patients were randomized to chemotherapy plus endocrine therapy versus endocrine therapy before. That's of course were in the intermediate risk patients in the TAILORx study, and the borderline here for the high risk was 25. So there looks like there was no benefit with chemotherapy in patients with low recurrence score, that below 11, and again the intermediate risk patients. However, in the young patients or the premenopausal patients, there was minimal benefit. You can see that in the subsequent slides, Nuran. And if you look into those patients, it looks like it's up to 9%. You could see some difference in the intermediate risk patients. And a similar approach was seen in the RxPONDER, which was limited to the N1 disease. Again, minimal benefit in everyone, but in patients with premenopausal patients, it looks like it's more than 5%. That's usually the prescription cutoff for many of us to prescribe chemotherapy. Again, as Dr. Ayoubi just mentioned, we're not sure if that's because of the chemo or because of the ovarian function suppression, because by hormonal treatment here, most patients receive tamoxifen only, which is not the current standard of care for the majority of the patients who would require ovarian function suppression, either with tamoxifen or with an aromatase inhibitor. So chemotherapy, as we know, result in ovarian function suppression and permanent, actually, ovarian failure for many patients, for like around half of the patients between or above 40 years. So that's why the benefit in the premenopausal might be derived from the hormonal effect of chemotherapy rather than the chemotherapy itself.
At this point, our patient has Oncotype DX results, and the recurrence score was 68%, with a distant recurrence risk at 9 years more than 39%, and the absolute benefit for therapy is more than 15%. Our next question is, At this page, at the same report, the results showed an ER negative 4.8 and the PR negative and HER2 negative quantitative single gene scores. Will we consider this patient is endocrine positive or a negative? This is a question.
Can you get back to the previous slide?
Yes.
For that lady, if you look at the bottom of this slide, again, every one of us, we look at the recurrence score for that. For that's why if you look at that 68, well, that's very high risk. So we are sure that this lady would have a poor prognosis and she will need to receive chemotherapy with the chemotherapy benefit more than 15%. So that's very high risk. Again, now we're totally out of the RxPONDER or the TAILORx dilemma. So this lady would need to receive chemotherapy anyway. But what was really surprising, if you look at the bottom of the slide, because many of us do not look into that part, you could have the Oncotype DX usually always provide an estrogen receptor expression and progesterone receptor expression scale, and that's not a valid scale similar. That's what we have of the immunohistochemistry to use to guide the immunotherapy, to guide the hormonal therapy or not. But for a low expression like that, she looks like triple negative patients if you look into the messenger RNA expression. And while we know that the messenger RNA expression is concordant with the immunohistochemistry usually, but here it was discordant. Actually, we did retest the biopsy results because we had a core biopsy before we took the sample, they took the surgery, and it again, in addition to the surgical specimen, also the true cut biopsy showed that we have estrogen receptor positivity with the the majority of cells that are positive. So that's a real bit surprising here. But what we should also look at, I think, for every patient, the degree of expression of the messenger RNA, because we might find some tricky cases like that.
Dr. Essam, what about the surgical specimen? Was the ER/PR tested on the final surgical specimen?
Yes, it was positive on the final surgical specimen. And actually, because the Oncotype guys, they have the block now, so we did retest in another lab the core biopsy that was that we did have, because we didn't ship the core biopsy. Of course, that was tested firsthand, so we were sure that she had an ER positive and HER2 negative. But after we gone to surgery and we did the surgical specimen, it ended up to have ER positive. We repeated again on another lab in the core biopsy, because now the block at the tissue is out there at in California, so we do not have it.
Yeah, maybe so there is some tumor heterogeneity, so it's not all uniformly expressing the same signal of ER/PR.
Yeah. But with that very high recurrence score, well, the question of chemotherapy versus no chemo here was more easier, actually.
Yeah, and I want to add a point. So this is a great example of how Oncotype changed the way we think about breast cancer, right? And the benefit of chemotherapy. Because it used to be the case that many patients would get chemotherapy, and then we didn't really know its sensitivity to chemo. But Oncotype just said, no, clinical parameters do not really reflect biology. So, in a patient like that, I'm not sure what the Ki-67 was. I think you might have mentioned it. Was it initially?
It was 28%.
28. So by the St. Gallen classification, she would be a luminal B, correct? But this exhibits a basal-like rather than a luminal B behavior. Oncotype doesn't give us this distinction. Some other tests like MemmaPrint and AutoR would just flat out tell us tell us exactly the intrinsic subtype, and I think it helps. There is an ongoing study, and maybe Dr. Ayubi knows about it, the SWOG 2206. So SWOG 2206 are looking for patients who are ER/PR positive, HER2 negative disease, who have elevated R score or Oncotype with an intrinsic subtype that high 2, with the memoprint high 2 subtype. And these are usually the ones that are at the very end of the spectrum on Oncotype like this. And these are typically the ones that are basal in nature and have immune inflammation. And they're adding durvalumab to these patients on top of neoadjuvant chemotherapy. The reason I'm bringing this into our discussion is when they initially approached SWOG, SWOG said, well, how many patients do you think have ER/PR positive and they're going to turn out basal or high 2? And it turned out it was actually a good chunk of patients, almost close to about 15%. We just never test these patients. And more importantly, the grade and the Ki-67 were not predictive of patients having basal, intrinsic subtyping. So you'd see these zebras out there, not common, but you see them, and then they tend to benefit dramatically from chemotherapy and possibly the addition of immunotherapy, which we tested.
So in fact, it's like after the presentation is over, I can share some slides to highlight what you just mentioned, really depending on how much time we have. But let's keep going with the presentation, and then if we have time, I'll share some of these results with you.
مهتم بالأونكولوجي؟ دلوقتي لو بتحضر ABCDE Tumor Boards لايف مش هتضيع وقت وهتاخد CMEs معتمدة. لو مهتم دوس على الآي اللي فوق.
We have another surprise that the patient did at this point the patient advised for a chemotherapy, fertility preservation, and genetic counseling, and surprising that she has a BRCA2 gene mutation, and that's all. She has finished her chemotherapy 4 cycles AC protocol, followed by 12 weeks of paclitaxel, and advised for post-operative radiotherapy. And the question is to give the patient endocrine therapy or not, to give her an adjuvant Olaparib or not, or considering her a high risk and give her CDK4/6 inhibitor. And thank you.
Well, those are the questions that, again, we're not sure of after that discordance. But the idea that that was mentioned by Dr. Khanani, that the most of them are or some of them are basal. Well, that's one. Our case is one example of that. She has a BRCA mutation, so that's typically very good basal one, and who do respond to chemotherapy. But the point is, if we treat her, or if you think of her like a triple negative breast cancer, then she would be fit in the Olympia study, where they did recruit triple negative patients, but those who have T2N0 or more, and she fits in that. But if we consider her as an endocrine ER positive, then she would not be eligible for the Olympia study. Did include patients who have 4 or more positive lymph nodes only in the ER positive patients. Again, we believe that this lady would behave like the ER negative mostly. And finally, the endocrine therapy and CDK4/6 inhibitor or not. Again, I would love to hear all of your opinion. I'll tell you my opinion at last.
Can I share a few slides with you to give you my opinion?
Sure. That was our last slide.
Okay.
You can stop sharing, Nuran, and Dr. Ayubi would share.
I actually have a very relevant case to this discussion, so I'm sending a request to share my slides because I think somebody has to grant me permission.
Please stop sharing, Nuran.
Yes. Okay. Share. Okay, so I'll share a couple of slides here. Okay, so this is actually a patient that I saw in clinic maybe 3 years ago, but I just want to mark this down. Okay. Where is the case? Okay, I'll just download the PDF because it has a nice picture. Okay, so this is my patient that I think like I treated 3.5 years ago. So this is the way that she presented to my clinic. This is the right breast. It was full of cancer, about a 6 centimeter tumor, and it looked super inflammatory. So this is the best picture that we have, but like I had other close-up pictures that I lost on my phone, so I didn't get a chance to get like better pictures. But this patient had this cancer develop over maybe a month or two. So like she had completely normal breasts, and then like within a couple of months, she had very severe clinical presentation that's like 100% looking inflammatory like. So the surprise here was that her ER was 5 out of 8 and PR 0. So she, by IHC, she had hormone positive breast cancer. So ER positive, PR 0, HER2 0. This is a picture showing the tumor infiltrating lymphocytes, but this is beyond the scope of the talk today. But then I did a similar test to the Oncotype, which is called MammaPrint, and I know that it's not a very famous test. I know that the market is pretty much predominated by Oncotype, but this test is called MammaPrint, and the way MammaPrint works is that it gives you high risk versus low risk. Anything above the 0 is low risk. Anything below the 0 going towards the negative is high risk. So this patient actually, her score came back as -1, meaning like really way into the high risk 2. So with MammaPrint, we subclassify patients into high risk 1 and 2. Most of the patients, like Dr. Khanani said, are high risk 1, meaning the luminal Bs, and only about 15% of the patients will be high risk 2, meaning super ultra high risk. And these are the basal ones, like the ones that you guys presented in today's case. So that would be a basal type, and that would be a very high risk, not just high, but not just high 1, but high 2. So when I saw this for my patient, that she was high risk 2, and I know that she would qualify. Well, that was 3 years ago, before we even had the SWOG study. I will show you very quickly that SWOG study. Where's that SWOG study? Are you following, or am I confusing everyone by speaking fast?
No, are you following you?
Yeah, let me just see where that SWOG, this here. This is the reason why we have that SWOG study, is because the patients that fall here in the higher risk 2 category that tend to have the basal subtype resembling triple negative, they found out from multiple arms in the very famous landmark trial I-SPY that these patients, like every time you add immunotherapy to these patients, every time you add it to whatever treatment arm that you're using, the people with high risk 2 tend to have a complete response in the neoadjuvant setting. So this is why now we have that SWOG study that is going to now recruit patients with a MammaPrint high risk 2, and they're going to give them neoadjuvant chemotherapy like the triple negative breast cancer patients, and they're going to add immunotherapy. In this study, it's going to be durvalumab to these patients. So we're going to randomize them to ACT versus ACT plus durvalumab for the experimental arm, to see if immunotherapy also is going to improve the results of these patients. Now, this patient of mine here, what I did, because like we didn't have the SWOG study open 3 years ago, was that I got her compassionate use pembrolizumab. So I treated her like triple negative breast cancer. So, well, she had a ton of involved lymph nodes by MRI. So she had a very big breast mass, and she had like 2 or 3 very big lymph nodes in the axilla. So I treated her neoadjuvantly like triple negative with something similar to the Keynote 522. So I gave her ACT, added carbo. Carbo is cheap, so it was approved by her insurance. But then I got compassionate use pembrolizumab. And then, so she got all of that neoadjuvantly. And at the time of surgery, she had a mastectomy, axillary lymph node dissection, and she had a complete response. And this is why I was able to publish the case, because that was a little bit of a futuristic treatment before we even have the SWOG study. If we had that SWOG study open, I would have enrolled her. And then she continues to be disease-free now, like maybe 3.5 years after treatment. And when it comes to the question about hormonal therapy, she got tamoxifen, and then she got sick of it because she had irregular uterine bleeding, and she didn't want to continue on it. And From doing some research on these cases that express the ER receptor but actually behave like triple negative, it looks like some estrogen expression can happen by IHC, but then the actual gene is not functioning. There's no downstream signaling that really makes that tumor hormonal responsive. So she quit taking her tamoxifen after 1 year and she hasn't recurred. So that was what I wanted to share with you. Aberrant expression of estrogen, but the tumor is really not estrogen driven. Thank you.
Thank you so
Yeah,
much,
that's
Dr. Ayub.
amazing.
Beautiful summary of this
But
conversation. Yeah.
that's very interesting. So you had a very, very similar case. And again, uh, uh, I think that's the way to go. Well, that's what I did prescribe to my patients. I did not, I discussed with her the idea of endocrine therapy. She's young. She doesn't wish to go for the whole toxicities of endocrine therapy. And well, we've also discussed with her insurance the idea of Olaparib. And they did agree. So we gave her, prescribed her 1 year of Olaparib. So she's basal and she behaved like triple negative though. So I think she might benefit from the addition. We didn't have the chance to give her neoadjuvant chemo, that lady, because she did go for upfront surgery guided by the immunohistochemistry alone. And she looked like an early disease. So again, after chemo we've given her, in addition to radiation, Olaparib for 1 year, and we wish she would go the same disease free like your patient. But that she's now only 6 months from end of chemo.
Now, the real question, I think, Dr. Lai, would be in the benefit of endocrine therapy, which I think it's more controversial, actually. Like, I think it's easy to say Olaparib because at the end, Olympia did allow ER positive. In fact, the majority were ER positive. So you're not. But the benefit of of estrogen hormone blockade in this patient, I mean, we can argue both ways. We can make an argument that it's basal. We don't know really if there's any benefit. But in the same line, in fact, this passed ASCO, and it was published now, the Mayo Clinic experience on low ER 0 to 10%. And most of these patients have very low expression to none. Probably most of them are high 2 or basal. But they did see some benefit in these patients who received endocrine therapy, which was very surprising. Not to say it's a similar case, but I guess it argues against not using endocrine therapy still for these patients as long as we have estrogen receptors still positivity. So again, I think it's not easy to generalize, but this is the type of patient who I would just tell them, look, there probably is some benefit, maybe very small. We don't know. We don't have any data on it. But I would leave the discussion to the division to the patient.
Maybe you would have low threshold to stop the treatment if they have a lot of side effects, because then maybe the benefit would be marginal. Yes, there is benefit. So like the way I tend to think about these cases is that it's annoyingly positive. So 1 to 10%, what do we make of it? It's positive, but it's annoying, and it's enough to disqualify them from most of the clinical trials that we have. And yes, there is a little bit of benefit, but not a whole lot of benefit. So I gave my patient tamoxifen, but then as soon as she started to have problems, I'm like, okay, maybe it's not worth it, because there's got to be a balance between the benefit and the side effects.
Yeah.
Yeah, I have a
Well,
question with you.
our patient actually
about
was on LHRH agonist during chemo. So one taste of the side effects of the endocrine therapy with the hot flushes and all that, again, made her want to stop chemo. Well, again, so that's very similar to your approach. Of course, tamoxifen is much easier to prescribe, and it's the preferred for many of us for ER low patients, where we tend to give them tamoxifen, and that's easier to tolerate. And if they do not tolerate, then we would love to stop quickly.
And would you consider giving ribociclib as adjuvant for this case?
Well, that's one of the options if you consider to treat her like an ER positive patient. But for me, I thought that I would treat her like triple negative, so that's why I did add Olaparib instead of ribo. well, we've did some data, some studies on the impact of BRCA mutation in patients and on the outcome of endocrine therapy and CDK4/6 inhibitors. Of course, it worked, but it worked much less in BRCA positive patients compared to BRCA negative patients. And that's true for the endocrine therapy, and that's also true for the CDK4/6 inhibitors. Again, that doesn't mean like endocrine therapy that doesn't work at all. But if I'm going to choose one between both in a patient who is ER positive, that's a luminal disease, I would be more inclined to use Olaparib. But if I would choose in a lady like that, we have a proof of being basal, then I would go for Olaparib without question. I don't know what the other panelists would consider.
Yeah, I think Olaparib is more targeted and CDK4/6 is more generic. So if that patient has the BRCA2, I would really favor doing Olaparib. And to your point, the Memorial and Sloan Kettering also published data but that was in the metastatic setting that showed that the patients with the BRCA mutations, they don't really benefit from CDK4/6 inhibitors in first-line treatment. The average time of response in first line is about 2 years, but the BRCA patients tend to have way less PFS. So I think for her, being more targeted is the way to go. And I would really choose Olaparib for her like you did.
So
I
you're
agree.
now moving forward to do
دكتور
this genetic
دكتور لؤي دكتور لؤي كنت عايزه اسال حضرتك هل احنا عملنا ريبيتيشن للاميونوهيستوكيمستري على الاوبرتيف سبيسمن؟
Dr. Asma, can we ask a question in English, please? Because we have people not non-Arabic.
دكتور لؤي, did you repeat immunohistochemistry on operative specimen?
You're muted, Dr. SM, you are muted.
Sorry, we did do the immunohistochemistry 3 times, 2 on the core biopsy and 1 in the operative specimen. And actually we did that because we wanted to answer the question of endocrine therapy or not. Well, and they came out to have estrogen receptor positive at different concentrations. So again, she has an ER expression. Maybe that's an ER heterogeneous disease. So that might affect me.
Can we combine endocrine therapy with Olaparib in this situation due to the heterogeneity of the disease?
Typically we can, but for patients who are not tolerating well, we did prescribe her LHRH agonist during chemo to try to preserve some ovarian function, while that of course causes some menopausal symptoms, and she wasn't very well tolerating them. So and we discussed that we expected some benefit. We've showed her some of the ER low data, but again, she decided to stop. She's a scientist, by the way, so she decided to stop the endocrine therapy and to go for the Olaparib alone.
Can I ask one more question about the case?
Sure.
So what type of chemotherapy did you decide to go with for that patient?
Full course. Well, the 4-AC and 4-taxane. We did not put carboplatin, but we did use 8 cycles of chemo. We have some data that in those with very high recurrence score, they need to go for the full data. And again, even if she didn't have that low estrogen receptor expression by the Oncotype, even if she didn't have that, but if she had an full ER positive disease but had a very high recurrence score, even though I would have gone for the full 8 courses, because we might consider the short course of chemo, the non-anthracycline for some patients with intermediate risk disease, but for those with a very high risk disease like that and very young age like that, and with the hint of that we might consider that not be a basal, I think the full course of chemo is even not enough for some patients.
Yeah.
I want to add a tiny addition to that very last comment. I think, and you're probably aware of these data, Dr. Lai, but in San Antonio, not that past one, the one prior, 2024, I think there were data presented on the with the TAILORx, it's a combined it's TAILORx data on Oncotype of 31, I think, and above. And then they
I
benefit
think 35. I think 35 and above.
right, and then that they benefit from anthracycline. Similar data are actually presented for like Dr. Alyoubi, right, for high 2 on MemPrint, also for benefit of anthracycline.
Yeah, the high 2s are the ones who benefit. The high 1s don't. The high 1s just benefit from TC.
Yeah.
And they were actually a little bit harmed from anthracyclines, but high 2, they do benefit from anthracyclines in the neoadjuvant and adjuvant setting. Okay, can I ask one more question, just like to be devil's advocate? And this is a surgical question. So this patient went for, what did she go for? Lumpectomy or mastectomy?
Lumpectomy.
Okay, why did she have axillary lymph node dissection?
She had a sentinel lymph node. She had a
Sentinel?
sentinel
Okay.
lymph node. Only she removed 3 lymph nodes, and one of them had a micrometastatic less than 2 millimeters.
So okay, so for whoever maybe prepared the slides, there is a big distinction between sentinel lymph node and axillary. And I think like what they had here is that she had axillary lymph node dissection, so she actually had sentinel lymph node biopsy.
Yes, sentinel. Well, that might be wrong in the slides, but I'm not sure. But she had only 3 lymph nodes removed.
Okay.
So that's
only 3.
sentinel lymph node. Yeah. So and she had a micrometastasis. So they did not go for any further dissection. Well, we don't go for further dissection for most of the patients now.
Good.
عشان طريق الماتش في أمريكا طويل ومحتاج توجيه صح، ABCDE بتوفر لك منتورشيب مباشر مع دكاترة ريزيدنتس وأتندنج شغالين فعليا في أمريكا، هينقلوا ليك الخبرة اللي تخليك جاهز لكل خطوة. لو مهتم دوس على اللي فوق.
Well, here in Egypt we don't do. I'm not sure, Dr. Alyoubi or Dr. Khanani, do you go for biopsy? Well, if you're going to recruit for the SWOG study, then mostly you would go. But I'm not sure. I don't know what you do in the regular practice.
In my where I practice, we're kind of divided. So I partner with a surgeon, and then we practice out of a different location, and we're very futuristic, and we really like to run our mamma prints on all the cores, like the TrueCut biopsies. But then at other locations in the same institution, we have a lot of people that hate mamma print, and they only like Oncotype, and they'll only get it on the surgical specimen. But I always like to get the test on the fine needle aspiration biopsy, because then it guides my patients. Because if I want to enroll in the SWOG study, I have to have a test result before the surgery, especially for these patients with ERPR low, because I'll know that maybe they'll be high risk too. Ahmed, Khanani, what do you do?
Between Oncotype and MemPrint, you mean?
Or do you run your test on the fine needle biopsy, or do you wait until the surgery?
Well, they publish a lot of validation studies, usually actually around the COVID time, and they're the same. I like to send it from the biopsy simply because it gives me ample time to kind of prepare for the discussions and no surprises. And by the time I have her surgery, I already know a good solid plan. And then obviously many of these patients too, especially the younger ones, there's a lot of now studies that compete on the sequence of therapy. So, the offset study is a good example. We also have some new adjuvant endocrine therapy studies. So a lot of these patients, and for me to actually properly triage them, I need to know what their RS score from earlier on. If they have a low RS score, I know they might not need chemo, so I give them neoadjuvant endocrine therapy. If they have a high RS score, they might need chemotherapy, but they can also go on offset study, which are randomized to either chemo or ovarian function suppression. So depending on how high the RS score, so because of just due to the logistics of the clinical trials that we have at Baylor, I tend to do it on the biopsy to try to triage and direction of treatment.
So that offset study is actually the flip side of the patient that we have. It's for patients that have low risk oncotypes. Now we're going to ask the question, so do these patients, if we make them postmenopausal,
low and intermediate, and the intermediate and the premenopausal,
can they forego chemotherapy? So if we make all of these patients postmenopausal, would they have the exact same guidelines as the postmenopausal patients? So we have that study now that's open at multiple centers. We enroll these patients, and hopefully the results in 2036 are going to be released, and hopefully the results will show that if you give ovarian suppression to all these women, hopefully they won't need chemotherapy if they have node-positive disease. Yeah, and also, like, I really wanted to add one little thing is that in the US, the patients, especially the affluent patients that are well educated, they can be somewhat entitled. So I know that in Egypt, if you tell the patient jump, they'll tell you how high. Like, they don't even argue with the physician. The physician is like got to them. But here in the US, the patients will tell you, this is what's going on with my life. And let's say, like, this is when I'm going to have the surgery because I have 2 weddings coming up. I don't want to have to lose my hair. So I'm not ready for that surgery for another 6 months. So if we do the Oncotype, let's say, or mamma print on the fine needle biopsy, and they come back low risk, we know that we can afford giving them the endocrine therapy for 6 months because they're not going to need any chemo. And then we can delay that surgery for 6 months because they'll just like put their foot down and say, I'm not having that surgery. So it really gives us more insight into the tumor so that we can plan what to do for these patients and kind of meet their expectations and timelines sometimes.
That's very interesting, of course. But in Egypt here, we have a problem with the access to the Oncotype DX, even for those patients who are typically within the TAILORx or the RxPONDER pool. So that's one additional problem into requesting them, where we might need them more to define which way to go for neoadjuvant chemo, for example, or for only surgery if she came out to have a
Did
luminal
your
A
patient
or
have insurance?
most of the Egyptian insurance do not cover Oncotype DX, so they cover the chemo, the endocrine therapy, but they do not cover tests sent outside of Egypt. So
did your patient have to pay out of pocket, or did she have a good insurance that covered it?
Most of them do have out of pocket. They do pay out of pocket for the Oncotype or the mamma print or anything like that. So that lady, for example, she did request it out of her pocket.
And may I ask, like, how much it costs? Because I don't know.
It's usually all the 3 common gene expression profiles. It's between $3,000 and $4,000 US. So that's the price they usually pay.
Okay.
But is that different from what's there in the United States if they have to pay out of pocket?
They never have to pay out of pocket, and this is why I don't know the prices of any services. And also, like, as a cultural thing in the US, patients will never pay out of pocket for anything, so they'd rather die. Like, if nothing is covered, then they won't get it. They won't pay. Like the Egyptians, like, they're used to that.
There are patients who might be self-pay, they ran out of their insurance and whatnot. But then there are programs to allow them to kind of pay. But most of the time, because Oncotype and a lot of these are genomic tests, so they can actually try to bill insurance, but whatever that they can get out of insurance, they will take it, but then they will not bill the patient. Or in other words, even if they send a bill to the patient, there is no liability if patients do not pay back. It does not get collected. Because these are not, because services rendered in like a hospital setting or a clinical setting is different, but these tests are treated a little bit differently. So there are very little payment issues most of the time.
Yeah, they have an expression. They'll say the company will eat the cost. They'll swallow it, and then they'll just give the test for free to the patient.
Okay, any questions from the attendees?
In other questions, I think we have one question in the chat, but I think we answered it already. I lost the question 1 second.
I think it was
there are many
about
questions
sequencing.
regarding the registration process. There are many questions regarding the registration process. So.
Yeah, we'll take care of this. But there was a question about the sequence of the Olaparib and
Olaparib and Verzenio.
course.
Yeah. I think that the question, I think we answered it, but really
Yeah,
because we're treating this patient in ER positive, I think we can do with what has been done already with Dr. Loai.
Yeah, but in general, I think we can sequence Olaparib and the CDK. We
Okay.
can give it concurrently or no?
No, not. I don't think we can give it concurrently. I think you can technically. This is off label because the ones who were on Olaparib and the Olympia didn't get CDK4/6 and vice versa. However, most of my colleagues at least and anecdotes that you can finish your Olaparib and then go in with the CDK4/6 for 2 to 3 years if you really truly have a patient that meets both.
Yeah.
Well, this is very difficult to do after chemo and full 1 year
Oh
of
yeah.
Olaparib. That's very difficult
Yeah,
to
but you know,
tolerate.
you'll have patients who come in with the papers and tell me, okay, I need to get 1, 2, and 3. So yeah, it's hit or miss. You have both. But yes, it's going to be a little challenging for sure for all these patients.
خطوة واحدة منك بتبني مستقبل دكتور كامل. في ABCDE بنجمع تبرعاتكم عشان نوفر جرانتس تدعم دكاترتنا ماديا ومعنويا في طريق الماتش الصعب. بمساهمتك انت مش بس تتبرع بفلوس، انت بتشارك في نجاح دكتور هينقذ حياة آلاف بعدين. ساهم معانا في الفند النهاردة وكن جزء من حلمهم. لو مهتم دوس على الآي اللي فوق.
So if we don't have any more questions about this presentation, I just like really wanted to maybe put a seed for a project. And I think it's going to be very relevant in Egypt. And I'm actually going to run it in the US too. So if anybody has interest, maybe you guys can get together and you can do it. It can be like a nice poster presentation. So it's a very different topic though. So, you know, maybe a question for Dr. Esim. Do we treat, let's say, triple negative patients and HER2 positive patients with neoadjuvant approach if they qualify for it?
Yeah.
Okay.
Yeah.
So we know that if we treat these patients neoadjuvantly, I mean, the hope is for them to achieve a path CR. And then if they don't achieve a path CR, especially in the axilla, the standard of care is to do axillary lymph node dissection. And
Yes.
there's been a lot of publications, like some of them like don't have mature follow-up, and there's the Alliance trial, B51, all that stuff like, but just like focusing on the Alliance trial, we don't have the final results. This is going to take 5 or 6 more years. But now in the US, what I've been noticing is that all the surgeons are moving away from doing this standard of care axillary lymph node dissection. So even if they end up with 1 positive lymph node, they just leave the patient alone. They never take her back to surgery. So it's a very simple project because there's a lot of physicians that are applying for residency in the US and they want to have some type of research that is published. We can just like do a survey, send some questionnaires to all the surgeons that you can reach. Like, I don't know where you practice out of, but like maybe like we could have Mansoura, Alexandria, Cairo, and then maybe if we have like 70 surgeons answer those that questionnaire, at least we'll see what the trend is like. And it's going to be just like describing the trend, like no intervention, just describing the trend. And then we can come up with that questionnaire, and then we can ask them why they're choosing to do what they're doing. And then we can ask them like, do you know about the results of that trial, that trial, that trial? At least like we'll know how they're thinking about these cases. That's it. And then it can be a poster publication in one of those international conferences like Miami Breast or some other even regional conference.
That's very interesting. That's very interesting.
Yeah.
I did some similar survey studies for physician reported outcomes or practices, and they're easy to do. You can just design that on a like Google form or something. So it takes a few time, and invitation of the surgeons from all over Egypt is not very difficult. Well, you can find their numbers on your phone book. So we send them messages or emails, and then they tend to respond usually in the rate of 50%. They do respond. So that's okay for inviting most of the breast surgeon from Egypt. So again, if you would have also a USA sample of surgeons to see what will they do, that's interesting.
Yeah, we could do a comparison between the practices across different geographic locations. Yeah. Okay.
Sure.
So if anyone is
That would be
interested,
great. I'd love to have your contact. Maybe Manar or Mustafa would share our emails together so that we'd catch up on that over email.
sounds
Yeah,
good.
that would be a good idea. If you can email us, we are already on the email invite, so you can just reply to email with the idea, what
Yeah,
is
okay.
needed, and we can work on that.
Sounds good. Thank you.
Thank
Any
you.
other questions? Mhm. Okay, thank you, everyone. Sorry, I couldn't join at the beginning. They called me for backup. But so this like our first meeting with the CME accredited, so it's a good thing we have like a big number of attendees this time. So it's nice. Looking forward for our next meeting.
Thank you, Mustafa. Thank you all for the great meeting. Really enjoyed
Thank
that.
you so much.
Thank you.
Thank you, everyone.
Thank you.